and good afternoon, everyone. It's a pleasure to be back at events led by Path for a simple reason that there are many young folks who are interacting with the digital health space, which is a new space. And while when I started working and when I was interacting within the Ministry of Health space, I could sense that there were a lot of gray hairs within the ministry, but this is a space which is much more energetic and much more newer. And the conversation is also much more dynamic and shows that the health can move forward, and there are new ideas which can be discussed in the health space. So with that brief preamble, I will give you a brief overview of what is happening in the digital health mission, which I'm sure, many of you would be aware that, and all of you would also be working. But how I am thinking, and I'll quickly check also. What I am thinking is that give you an overview where we have started, where we are today, and a few courses with respect to how National Health Authority is thinking about the next course, that is the next 5 years. So this is what I have in mind. But before that, I just want to get a sense how many of you here have an ABHA number? Oh, that's a bummer. Okay, so then I'll have to give you a bit overview about ABHA number as well, so that I think all of us are on the same page in that sense. Okay, can we have the slides? Okay, so Ayushman Bharat Digital Mission, when it was launched in 2020, had a brief background in the National Health Policy, which is 2017 document by the Ministry of Health and Family Welfare. There is a very small section, and that was, I would say, a bit visionary on the part of those who made it, that they kept a small section of digital health ecosystem within the entire national health policy. Otherwise, generally when you hear about health policy, it is mostly about reducing IMR, MMR, child mortality and related aspects, TB, which are important. I'm not saying that they aren't important, they are important, but they can also be a way forward where a small catalyst can help in achieving all these things. And that's where precisely digital health entirely fits in, and that was also the goal with which it was placed within the national health policy. And subsequently, the Niti Aayog picked up the National Health Stack document. If you have not read it, again, it's a very good document as far as the imagination is concerned. So, a very fine policy document. You should give it a read. And in August 2020, from the ramparts of the Red Fort, the Honorable Prime Minister announced the Digital Health Mission. So that is a brief journey of Digital Health Mission, where it started and where its origins are. But if you see what is the problem that the Digital Health Mission is trying to solve, if I want to not go into the vision statement, but from a practicality point of view, and many of you might also be interacting with these health systems, be it RCH, be it Nikshay, be it WCD, Poshan Integration, Dialysis Program, PMJ, so on and so forth. So all these systems have been existing in the health, I would say, ecosystem for almost, let's say, close to 2 decades. And all of them have created a parallel hierarchy per se. I'll give you a small example, because this is something I was dealing in the morning, that as simple as the Nikshay program, when it started demarcating the facilities and the districts, it started its own Nikshay hierarchy. They were not using the LGD codes. Right, so what it does, as simple as that, LGD code is a local government directory which gives a specific address to each and every sub-district, village, taluka in the country, but they were not using it when the program was designed. If today I want to superimpose and see how many programs are working in one particular district, I can't, because Nikshay is following a different hierarchy. So we are in these silos as far as the programs are concerned, and from a digital point of view. And many of you, if you are on the field, you would also see that the frontline worker is being asked to upload or put the information in separate portal. In this age of AI, where, because all of us are also users of one or other kind of software technology applications, it is single sign-on, right? You simply add your mobile number, everything will be fetched. So it's not an unsolved problem, it's a solved problem, but somehow the government system or the health system have not moved beyond the siloed approach. This is what ABDM precisely came into picture to target that. Can we avoid this siloed picture? From data, it's not just silo at a union level, it is siloed at every level. From a data perspective, from a process perspective, from a beneficiary perspective. if I identify one patient, let's say high risk pregnancy case in RCH, will she be able to get a express treatment under PMJ? That's a free treatment. The women should be able to avail that. But the system will not talk to each other and they will not flag it that this person requires a free treatment, even though the benefit exists, right? So the systems are not talking to each other, and that's where we are. And I think these are compromised quality of care, and these are just outcomes of what we see because of this siloed reality. Can we have a new paradigm which is stated within the digital health blueprint, where, because when we are talking about digital system, you or I are not interacting. So the trust, which is a human trust in the digital system, will be slightly different. It will not be a face-to-face connect or a human connect. It will have to be a digital connect, right? So that's where the digital health mission has envisioned that, can I have a scenario where the stakeholders who are interacting in a digital system have a trusted identity. So if tomorrow I say that this person is this by this number, then it should point to that person. And that is precisely when I asked the ABHA number from each one of you. That was the reason, because ABHA is your digital identifier in that digital ecosystem. That is your address, that is your virtual address. And that's why if you see the full form, it's also Ayushman Bharat Health Account, right? It's an account number where you can deposit your health records. And if that is an address, then all the programs which use your ABHA number can deposit your health records in the same account. You need that common identifier. So that's where the trust comes in. And if it is a unique identifier, then not every system need to create a separate identifier for you, separate address for you. It can be a common address for an individual. So if we can have that paradigm where we have everything digitized, we'll be able to have a system where the cost goes down, the data goes up. So you will have a low cost, high trust ecosystem that can drive innovation using data systems. If today, if I want to create a district profile using simply a data set, why that information, let's say, should only be with those program officer. If this information is available in a digital manner, you can fetch it. As a citizen, you should be able to fetch it. As a researcher, you should be able to see it. An ABDM dashboard is one of that identifier today. When you see that, okay, in this district, in this facility, this is the program, this is the record. That is transparency. That is data available to citizen to think about what is going on as far as the health is concerned. So, but from a larger point of view, where digital health mission fits in, it's actually a continuity in the digital public infrastructure story of India. It is not, separated from this entire DPI journey that we are having. The Aadhaar is very part of the single source of identity that I highlighted. The ABHA number is created via Aadhaar number. So no reinventing the wheel again and again. I'm using the existing system to give you that identifier. Similarly, if I have to create a healthcare professional registry, I will use that Aadhaar number as a common identifier. So it is using creating the system once and reusing in different system. So that's precisely where one of the dictums in the digital health blueprint is, you capture data once and you use it multiple times. That is the same principle that we are following here, so that there is no duplication at any level, right? So this is the vision statement for the Ayushman Bharat Digital Mission. The main point you will see is that I think this is one of the unique digital health or health missions which talks about security, privacy, openness, standards-based ecosystem within the healthcare ecosystem. Otherwise, most of the health missions are most focused on the outcomes, but this is doing the core work as far as the digital health mission is concerned. So confidentiality and privacy, and mind you, this mission was launched in 2020, even when the DPDP Act did not come into force. So this was aligned in the larger country's trajectory, because Sri Krishna committee had recommended a bill, and the entire digital health mission took those elements within itself, that what future privacy regime of India is going to be, and ABDM adopted all those principles while creating its mission statement. And this is again very standout feature as far as the digitization or healthcare, both the things are concerned. Slightly technical, but just wanted to highlight that how the entire architecture is layered. This is again the background work, that, as I highlighted, there is a cross-domain digital public goods layer, which is where we are leveraging the previous work which is done by the Ministry of Electronics or CDAC for e-sign, consent form, etc. On that, we are putting a identity layer, because before I give you services, I need to establish the identity of citizen, doctor, facilities. Once I have the identity, then I need to give you a data exchange layer, that can you talk to each other within a digital space. That's where the second layer comes in, the HICM. The third layer, you are talking to each other, but you need to also avail the services. You need to book the services. Today, right now, you are here and you want to search nearest PMJ hospital without going to a specific application or specific portal which you may not be aware of. That is democratizing the health services within the ecosystem. The unified health interface has a name akin to UPI, but the goal is same, that can I democratize the space as far as the health information is concerned. And the top layer is the claims exchange, because within the health space, unlike the payment space where every transaction has some commission, the healthcare space, the payment usually flows from the insurance companies, right? That is, or the other way is the citizens, the out-of-pocket expenditure. These are the only two ways in which the money is coming into the ecosystem. So the claims is also a very important part of this entire digital architecture, and given that government is also a very big payer, the Prime Minister's Jan Arogya Yojana, the Pradhan Mantri Jan Arogya Yojana, the world's largest health assurance scheme, it covers bottom 40%, close to 55 crore people, has an annual budget at a union level of 10,000 crores. So it is not a small amount of money which is getting into the ecosystem. So that is also something I need to make it a part of the entire digital health architecture, so that tomorrow if PMJ uses something, it should also be using the ABDM rails, right? The registries which I talked about, again, it's a refresher, as Sarah also mentioned, that Ayushman Bharat Health Account is for citizens, HPR is for professionals, HFR is for facilities. Professionals also is very important, because this is a very recurring phenomena in the Indian ecosystem, where we hear about it on a, I would say, monthly basis. That I think last week somebody reported from Madhya Pradesh that 2 of the doctors having the same name were working within the government system. Now, even government is not able to identify whether the certificates submitted by those individuals were genuine or not. How can we think that the citizens will be able to find, if you go to a doctor, whether that doctor is a genuine doctor or not? That is a genuine information asymmetry that exists in the system, right? So I need to give that information or tool to that citizen. Can you identify whether the doctor is a genuine doctor or not? Right? That's a problem we are facing in this ecosystem. So the HPR, using the idea of CoWIN credentials, where whenever you had your CoWIN certificate, there was a small QR code at the bottom. If you scan it, it used to tell that whether you have taken the dose or not, where you have taken it, and it was treated as an international passport as well. You could use it and travel across the country. So we use the same idea and put it in the doctor's registry. If the QR code is displayed at the facilities or the clinics, the patient can simply scan it. It's a trust builder. It's a trust marker. The doctors will also find it important and genuine, that, okay, if I put it, I am putting a certificate of markets. I mean, if I want to dub it out very simply, it's like a TripAdvisor restaurant certificate, right? There's a genuineness mark, and it's a good certificate mark that person is registered with the National Medical Commission or the National Dental Commission or Indian Nursing Council, and so on and so forth. And similarly for the facilities, right? So these all 3 registries, while they are doing a purpose in the physical world, which I just explained, but in the digital world, if you go to a doctor tomorrow, you also need the doctor's address, that what is that doctor ID, digital ID. I know the physical name and so on and so forth, but what is the digital ID? So that's where the HPR comes in. And similarly, the interaction between a doctor and a patient is happening in a physical facility. That's where the HFR comes in, that which is the digital facility where the interaction was happening in. So therefore, you see the location and the 2 stakeholders all need a digital identifier to box that interaction as a unique identity, unique transaction in the ecosystem, and that will create your digital health record with your identity, doctor's signature, and the facilities ID. I'll show you one example also. But again, I think I don't need to mention this, but this is the reality where all of your records either would be on Google Drive or your mails or your paper files spread across. If you're not from Delhi, then some records may be in, let's say, if you're from Kota, Rajasthan, then it is there, or Bareilly, but they are spread across. And today, if something happens, either I need to call the family member or the relative, where is the document, and then you need to search that document, and you have to find. And small hiccup also happens if something has either the how should I say it, something has spilled on it, or the ink has faded, or the worst case scenario, if the mouse has bitten. All these are practical possibilities, right? But this is actually my EHR, my electronic health record, which I have right now in my mobile phone. All the facilities that I have visited, all the immunization records I have taken, everything with me currently. If something is required from me at this moment, I can give that access immediately to anyone who requires. So this is a reality where, if I want to highlight, I don't know if it works. Okay. Yeah. So convening is something which I took 2 doses. One is in my hometown Bhilwara, which is also highlighting. I visited a primary health center in Corlim, Goa. That is also a record. Then I visited Lady Harding, got some lab tests done. AIMS New Delhi, CHC in Patna, District Hospital in Patna. All the records right now, if you ask me, I can show it to you. Right? So this is a real advantage, and on top of it, you can also manage your family's records. I mean, many of you are young and you will be stepping, or you are already doing it, managing it for your parents. You can also keep all these records in one place for them. That is also a genuine benefit which I have also discovered over the time while interacting with my batchmates, my friends, that if something happens to their parents, they don't know what is the medicine they are taking. I mean, how many of you would know that what is the medicine they are taking? And that is the first question doctor asks, kaun si dawai le rahe the? So these are genuine benefits as far as the physical world is concerned, but the digital world will have much larger benefits to the facilities, to the claims, to the insurance, whatever you are doing. So this is a reality, and this interoperable network is now I would say, it's not a work in progress, but this is something which we are experiencing it on a, I would say, I'll show numbers as well, but around 2.5 lakh facilities are already linking and creating those digital health records for citizens, right? This is a small utility which we developed on top of the Aabha number. This was a problem which, if you have visited, how many have visited the government hospitals ever? A queue problem, a rampant queue problem, right? You stand in the queue for God knows 1-2 hours just to get the registration slip. And if you have noticed closely, then the person who's behind the counter, behind the glass ceiling, is asking only 3 things: name, age, gender, and maybe your address. Where are you coming from? And then he does a basic triaging. Kahan dikhana hai aapko? What is the problem? Right? But this small interaction usually takes, anecdotally, and I also done it, somewhere around 2 minutes. If you are 60th in the queue, that's 120 minutes for you to reach the registration desk, right? For the small details that the person is asking. So what we did was that, using the ABDM identifiers, because in the Aabha number I have all your details. I just need to send that Aabha number to the facility, and then 50% of your job is done. It is remaining 50% triaging that still happens at the registration desk, but that is again a process change that will happen. But what we were able to do is that we were able to cut down the time, because as soon as I enter into the hospital, I am scanning a QR code which is there, and QR code is something most of the Indians are familiar with. I'm scanning it, I am directly going to the counter, and I'm saying my token number, which automatically fetches all my information, and then the person is only asking the department I want to visit. That has saved considerable amount of time, almost 50%. It has reduced it to 50%, and the testament to this is around 22 crore tokens have been issued so far, is working across all 36 union territories, close to 720 districts, 25,000 facilities, mostly government. So this is again a living reality. But one thing I also want to highlight, we also did a study with IHMR on this. They selected a few facility, a CHC, a district hospital, a super specialty in UP, and they were able to come down to a number which said that it saves around 22 minutes of time per patient. And if you multiply 22 minutes by 22 crore, then that's a person hour saved productivity, if I want to put it that way. So this is 22 minutes per patient is a very huge number. Yes, one interesting highlight which also came is that it is most effective where the foot flow or the footfall is higher, the flux is higher. If there's a small number of patients which are there, then the flux will be slightly less, right? So the time saving will be slightly less. Okay, this would be slightly blurred, but these are actually all the services that we have enabled. This is actually my profile which I am using to share the profile to the AIMS New Delhi to get a token number. So my Aadhaar number, address, gender, age, everything is directly shared with the hospital. That saves the entire time which I was highlighting. The another window that you see is the record that I'm getting on my phone. Again, AIMS Delhi record I can show at any point in time with me. The third is the consent request. So one important thing which has happened because of entire digital mission is that earlier the records that were actually yours, you had to ask hospitals that can you share the records with me, because the earlier paradigm prior to DPDP did not warrant them to share the records with the data principal, which is us. But with the entire DPDP Act coming into force and the ABDM architecture, it is actually putting the patient into the center of the conversations at the healthcare institution. So tomorrow, if I go to a facility and I want to share that record, the facility will share the consent with me, will raise the consent request with me. I will give the consent on my phone and then give it to the facility, and that too also for a specific period of time. That is again I can decide what time, what type of record I want to withdraw consent. Everything is again possible digitally. That's what I was highlighting, that while the front or the physical world has a limited implementation, but once you get into the depth of it, the use cases are I would say endless as far as digital health is concerned. And the fourth item is about the payments. There's again the similar queue thing also happens once you visit a doctor and you have to take a diagnostic test, right? So then again you have to stand in a queue to make a payment. Now in this age of UPI and other thing and all the requests that can come to your phone, this can also be digitized. So this is something we did with currently it is working in around 100 plus facility. We are increasing the reach and will be, because sometimes in many hospitals the amount is very minimal, 10 rupees, 1 rupees, 5 rupees, 20, 30 rupees, and for that you are just standing in queues. It can be easily done via UPI. Now one fact I want to also put here is that the idea is also not to say that everyone has to use this, right? Right to health is a fundamental right. I can't deny anyone health just because they don't have an Aadhaar number, right? But the point is that there are good number of individuals and people are comfortable with technology, people are comfortable with smartphone. If I can give that service to them on their smartphone, they are actually lesser burden on the administrative staff of the hospital. So the people who want to use cash, people who want to use something else, they will not be standing, they will be standing in queue, let's say, but they will not be clogged by those who can pay via, let's say, means like scan and pay, right? Similar example, I mean, DigiYatra, where the gate number 2 at T3 has the DigiYatra gates, but there are also normal gates. It does not say that everyone has to use a DigiYatra. Not everyone is comfortable in sharing their face credentials, but I have the option. Those who are comfortable, they can straight away walk in. Lesser burden on the CISF personnel who is standing at the gate, lesser burden on the people who are in the queue, because if I take out 2%, that is 4 minutes saved at that instance, and similarly here also. So idea is not to, let's say, entirely jeopardize the system and say everyone use digital means, otherwise I'll not give you health services. That is also not the point here. right? Two important things, because I think I have taken enough time, but this is how the entire blueprint works, that the identity is Abha. With Abha, I do the consent sharing, that is the HICM. If I want to do, once doctor has prescribed a lab test, I think the part team is also working on this in one of the state. If the prescription has been generated by a doctor, can it go through UHI, where I see the list of facilities or lab near me where I can book those services? And then if a payment has to be done, can it be done via NHCX? So entirely digital blueprint where the navigation can happen digitally. The record does not have to exit the system, and that is also an important concern, because in this again anecdote age of AI, everything can be modified by simply putting it to a Gemini, right? So it becomes very difficult for the payers also, whether the record is a genuine or not. But if it comes from directly from machine, it is a proof, right? This is also something which people confuse, that while we are making a digital system, is it centralizing everything, right? That is usually the notion that comes to our mind. But actually that is not the case. The government of India, the record that I showed to you, does not see any record. The entire architecture is federated in nature, which means the data stays where it is generated. It is not moving to a centralized server, it is not exposed to government, it is not exposed to anyone else. It is just putting citizen at the center, that you can access all of the records which you have. So no centralization, entirely federated architecture. It also has a good security reason behind it. Let's say if one node gets compromised, the rest of the node are safe, which means if one facility you are visiting, let's say ABCD hospital where you have visited in Delhi, had some cybersecurity breach, but your other records which are in different system will still be safe. So that's the idea behind this federated architecture that we highlight. In terms of number, this is where we are. 90 crore ABA, 100 crore health records, close to 9 lakh healthcare professionals, more than 5 lakh health facilities, and searches on UHI. So this is just getting, I would say, we are just getting started, because healthcare universe is vast. Health is a state subject also. On top of it, majority or a significant portion is also given by the private sector. So the private sector is also an equal stakeholder and equal part to this entire conversation. It is not just for the governments, right? This is where we usually say that ABDM does not build a solution. ABDM is not a solution. ABDM is not a platform. ABDM is an infrastructure. That is a distinction we need to make. Infrastructure is being leveraged by the solutions, right? If I again want to give a simple example, consider ABDM like roads and the solutions like the vehicles which are plying on it. It can be a truck, it can be a Alto, it can be a Vitara, Neon, Nexon, whatever you want to call it. All these facilities are there, and the hospital can pick and choose which facility, which software I want to use. Citizen can choose which PHR app I want to use. So that is an option which is given to the citizen, facility, doctors, all the relevant players in the health ecosystem. So this is one point. If I want to really say that what is one message I want you to take away, is that ABDM is not a platform. Next time somebody says, please correct them. It's an infrastructure. It's a common digital rail which will be used by all players, private, public, government programs, even NGOs who are here. If you are doing something, it can use ABDM rails to deliver your health services. Now, this is last part. I just want to apprise what NHA is also doing as far as the AI is concerned. See, AI without data is nothing. Entire prowess of AI runs on data. Now, what you have heard so far is that ABDM is trying to digitize the entire ecosystem, which means it is trying to curate and generate that data set. On top of it, we will be able to run AI engines. Otherwise, today, even if you want to use ChatGPT for health, Cloud Health, everything is trained on Western data sets. It is not on Indian data sets. And if we try to use them in the Indian context, it will drift like anything and it will have repercussions on lives of people. I mean, to give you a small example here, we were talking to IIT Delhi folks and they highlighted it to us that the breast cancer screening tools, which are usually prevalent in the Western world, have a onset of breast cancer in the women over there around age of 50-55. In India, it is 40-45. So if I use the same tool, the chances are that it will give me false negatives. I will miss those patients. If I'm directly using those tools, if I don't train them on the Indian data set, I don't train them Indian context, right? So therefore, generating data is important, curating that data is important, and then only the AI will be effective. We will be able to use AI for ourselves. Otherwise, we'll again be subjected to the tools with whom we don't have any control. So during the India Impact Summit, the National Health Authority under the aegis of the Ministry of Health, we launched the strategy for AI in healthcare for India, which is acronymed as SAHI. It has 32 specific recommendations across 5 different pillars, which is governance, data digital infrastructure, capacity building, which is very, very important when we are talking about digital health and AI. I mean, unfortunately, we will have to leapfrog, if I am not wrong, that we have not yet trained our workforce for the digital health. Now the AI is already here. So we'll have to maybe leapfrog and mix those things for our workforce. Research innovation, because we don't want AI solutions from, let's say, abroad. We want our native AI solutions to be generated here, kept here, so that these are sovereign models. These are used within the country using Indian data set. And that's where our population also, I mean, they also have a security concern here. And the last is, I think it is known to everyone, we are avid users of technology. So each and every company is coming to India for a simple thing. They want data, right? So there is an India need across them, but instead of just supplying data, we can also provide our solutions, right? So it is to, let's say, avoid the classic colonial trap of providing the raw materials and not the finished products. So we have to provide the finished products as well, as far as the AI is concerned. And this is where if I want to put AI and DPI together, so ABDM is your DPI rail, the AI should be riding on top of it, right? So you need your DPI rails to be perfect, you need states to be adopting it, and you also need capacity building. Without capacity building, nothing will move. I mean, we can make all the shiny presentations, shiny products, but till the time we don't train our workforce, we don't make it a rule to make a capacity building a mandatory part for any digital solution, I think we'll still be falling short. And then creation of high quality data set and then the final products is something we all need to do. So yeah, this is a QR code if you want to simply download the SAHI document. Again, it is also in the public domain. You can go to the abdm.gov.in. There also you will find the document. But yeah, this is all from my side, what we are trying to do with respect to DPI, AI, and the things that we are trying to do. Any question, I think I'll be happy to take those as well. Yeah. Okay, Sarah, we want to take it now or afterwards?
You can take it now.
Okay, sure.
Yes. Hello, sir.
Yep.
Thank you for your lecture. I'm Himanshi from University of Hyderabad, and my question is, as you mentioned about the decentralization of the information across the web of ABDM, and in the morning sessions, and also you mentioned it later in the part of your seminar, you mentioned about in the morning sessions they've mentioned that there is no enough data.
There is
no enough data to train the models.
Correct.
And wherein you have mentioned the decentralization. So how can we get the data which is actually localized among the Indian population in order to train the models?
Okay. So these two are not contradictions. These are in synergy. I'll explain if there's some confusion. So see, the fundamental premise is that I need data, right? In order to have those data set, the hospitals have to be digitized. That is, these are the two premises. Now, what ABDM is trying to do is that if they are getting their system for the first time digitized, you use the solutions which are in line with the ABDM standards. Now by ABDM standards, there are certain, let's say SNOMED CT codes are there, the LOIN codes are there, then the fire interoperability exchanges are there. So the ABDM enforces that interoperability within the system. But the data set that you are talking about for AI training is the next step of after I have done this, then in order to use it for researchers, for AI model training, then I have to cull out a specific part of it to create something which is called as golden data sets. So this will be done by the facilities themselves, right? The facilities we are digitizing, let's say you are in Hyderabad, right? So AIG hospitals. So AIG hospital can become I would say a localized instance of the population of that region, because AIG hospital being so vast and they also have a network, they can curate that data set and make it open for the AI researchers, that okay, if you want access to data set of this region, AIG hospital is that network institution who people can reach out. ICMR is trying to work with similar institutions, or let's call them anchor institutions, which will be spread across the country. There will be AIIMS around the country, but there will also be the private sector institutions, because they are also catering to a particular demography. So we need that representation of, age, gender, class, sex, everything. So these are important in terms of curation. So these are not two segregated tasks, these are the same part of the things. It is, if I want to use the slightly technical term, it's the secondary use of data. That data that is generated once, for the clinical purposes, it uses the ABDM minerals to come to you. For the secondary use, it is de-identified, anonymized, and then goes to the layer which can be used by the AI companies or researchers or any other relevant institution. Yeah. Yeah.
Thank you for the mic, and thank you, sir, for the wonderful and elaborate presentation. My name is Molly Dua. I'm a biotech graduate, recent graduate, and I am hoping to pursue a career in public health. When we talk about capacity building, who is responsible to conduct these sessions? And when you asked about the ABHA ID, where are we lacking, and why are people in this room particularly and all over our country, why don't we have the ID yet? Is it something that can be mandated? And since the conference here is about involvement of youth, so why is it not spoken about in such as colleges, and why was not my ID made during my college or my education years? Thank you.
Yeah, okay. So I'll ask the second question first. It's easy because and it is also represented across the other healthcare parameters as well, that the youth years are usually not the health-seeking population. They don't seek healthcare. Until unless something drastic happens, you don't go to healthcare. And therefore, if your interactions with the healthcare ecosystem is limited, then you will find lesser utility to create that ABHA number. That is the larger problem. But having said that, I think 90 crore is also not a small number. It is a very large number. But where we are lacking, that's what I'll highlight, is the use cases. That unlike a UPI, which you open, let's say, 3 times a day, you will not be opening any healthcare app. I mean, I'm just taking an example, let's say Tata MG. If you have in your phone, you will open it once a month. You will not open it every day. And that's where the interaction with that number or that ecosystem is very limited. So we need to find the ways where I can bring in that number and make it a part of daily conversation. Specifically, let's say for youth, we can tap into the wellness market, because I think people are tracking their sleep cycles, weight, calorie loss and everything. And these are also part of your wellness records, right? So there it can become, we are actually in talks with Apple, Google, Samsung, all these big companies also, that if they are generating those records, can they be given out as a wellness record to you? Right, so Samsung currently I think is powered by one of our integrators, which is EkaCare. So today, if you are a Samsung user, then you can link your wellness record within the Samsung application to the Aadhaar number. It may or may not be aware, the individual may or may not be aware at that point in time, but the utility actually comes in whenever you are experiencing some distress moment. That is the problem with healthcare. I mean, today, how many of you have a health insurance? A private health insurance, not the company one. And how many of you know how good it is? Unless you don't land in a hospital, you will not know how good it is. So your decisions currently for the health insurance is also based on some either metric or influencer or something else. That's the problem with products in healthcare, right? And that is also similar with Aadhaar number as well. Unless you don't feed the need that I need to keep all my records in one place, you will not require it. I mean, two of the categories that I could find, and again came from my friends group only. One was who had a kid recently. So he wanted to keep all her records in one place, right from immunization to whatever things that were happening since her birth. Right, so they felt a need that I need to keep immunization record and other treatment record. The second was with the aging parents, because the demand for healthcare also goes up for them. It may not be for you, but it is for them, and you will be managing on their behalf. So that's where also you feel a need to store records, at least for them, not for you, but for them. So these were the two use cases or I would say identifiers that I could see which can push the individuals in our age group to use Aadhaar number. May not be for us, but for our immediate near and dear ones. On the first part, on the capacity building, okay, it's a tricky part, but what we are trying to do at National Health Authority, and what we are trying to use the common framework of CBC. The Capacity Building Commission has notified something called FRAC, Framework of Role, Activity and Competencies. The reason we wanted to do this is that till now, whatever has happened in the ecosystem, let's say you launch an RCH application, then you are training the individual on an RCH application features. If you are launching an NCD application, you are training them on the NCD application features. So it's a very app specific training that you are doing them. And when some of our colleagues were doing this pilot of FRAC approach, we figured that the frontline workers in this case, if the phone hangs, they were not aware what to do. They knew how to operate the application, but they were not aware how to operate the phone, right? How to restart the phone. I mean, that is a known thing. If something goes off, you restart the phone, known to us. But the frontline workers didn't know about this, right? So that can be basic digital health tools which can be there, and this is not something of one entity should be, let's say, training the individuals on, but it can be, let's say, I mean, it's a hard task, but we'll have to agree on collectively that these are the things we are training people on, and therefore, if NHA is training on Aadhaar creation, it can be the same module can be used by the rest of the programs as well. So there will be requirement of close coordination with all the programs. And that's what we are here also trying to do in ABDM is we are not trying to create a separate wheel for ourselves. We are saying that, okay, if you use RCH, you need to be mindful of ABCD things. So that's what we are trying to do as far as the capacity building is concerned. And honestly, if you ask me, that is the toughest part. The tech is the easiest part. It can be built by a group of people, but if you have to train a close to 70 lakh strong workforce, then, and the levels are also different. The education levels are different, the professional level is also different, the age groups they are dealing is different, the type of disease they are dealing is different. So there is so much heterogeneity over there. So we need to work together to solve for it. And this is again open piece and open call for everyone that this is a piece which needs to be solved and needs all the young minds onto it. Yeah, thank you. Thank you.
Thank you so much, sir, for setting such a great context to this conversation and helping us better understand the larger digital health architecture, shaping healthcare delivery in India, particularly the examples that you gave. Building on that foundation, I'd like to invite Divya Malik from PATH, who will help us unpack the evolving medtech landscape and its growing intersection with digital health.
Thank you, Manya, and thank you, Himanshu. I mean, the problem statement that I wanted to bring about so that we talk about why technologies or medtech is important is something that you've already laid. And the audience now clearly understands that how the digital mission is trying to integrate a lot of gaps, try to leapfrog what is available, and you know, unify the healthcare in general. Also in that you mentioned how technologies need to be centered from India, need to be trained in our data sets. So I'll also talk about medtech in that lens, that also we are working very, very extensively. India as an ecosystem, we talk about our innovator landscape, it's huge. We're also working on the medtech in that sense. So just keeping a lens on, you know, taking you from very, very basics to what we do in medical technologies or how medical technologies are enabling. MedTech, as we define or as a common person would understand, can be any instrument, apparatus, or a machine. It could be an implant, it could be a reagent. It is a software or an equipment that is used by healthcare professionals. Now, why they use a MedTech is basically to either screen for a particular disease, to diagnose, as in confirm that that problem is there, to monitor and treat. And once you monitor and treat, you also manage the disease outcomes for that particular patient. While most of us can name a lot of medtech on our fingertips, an MRI, a CT scanner, an X-ray, these are very high-end and low-end, even a pulse oximeter technologies that we usually understand. But medtech is also emerging and evolving every day as our digital mission is, and as every country, not just India, is trying to digitize. And the problem statement that we see at the last mile, where technology can be an enabler, can help leapfrog, you know, this is why emerging technologies are coming. Now we have an X-ray is very easy to take, and a lot of things are very easy to miss in an X-ray. So we have AI, the way Himanshu was also talking about AI that integrates into a, you know, an AI radiology software that integrates and makes the X-ray read so flawlessly or easily that it's a decision support system for the doctor also, or the frontline worker. They understand when to plug this person into the next higher level of facility or to refer to this person in the right manner. Then we have digital stethoscopes. So there's a task shifting that technology is bringing nowadays. A very, very common example is a digital stethoscope where an A&M or an ASHA can also understand that, okay, I can hear a heart murmur or this patient needs to be referred, while in general her training does not allow her to classify that person for any disease. But a lot of proper negatives or people who don't need attention can be filtered, and that reduces the burden, introduces task shifting, improves the flow of the health systems that we are talking about, the overburdened. I'm sure you all have some time in your life visited a PHC to understand the burdens that we see. So there are smartphone-based diagnostics these days. Software as a medical device is something that is probably just 5-10 years old in you know, the world. And wearables, remote monitoring systems, and connected care infrastructure. These are the new medtech that we all talk about when we integrate them with the digital ecosystem. A little more understanding to medtech. I think already talked about the categories in which medtech is classified. Versus there is another one that I have not talked earlier, is disease surveillance. Apart from screening, diagnostics, and all this, disease surveillance is also something, early warning signals is also something. Now technology integration is playing a big role. A very, very technical purview on, you know, we develop a medical technology, but we do not know what to do after I have an idea, I have prepared something, I have done something. So there is a very, very extensive network of regulations or regulatory that we call is required in any country. Most common regulatory understanding that you guys have, everybody knows a EU CE or a US FDA. I'm sure you guys also know that India has its own stringent regulatory authority, like National Regulatory Authority, which we do not rely on any other, you know, US FDA or EU CE. So CDSCO is the main body where if I make a medtech technology, then I need to get it vetted and, you know, regulatory compliant with the Indian body. So Government of India in that sense is also enabling a lot of innovators, medtech development indigenously, that this is what we need to follow, this is how we develop technology. There are standards organizations, we all know ISO, we all know BSI. I mean, these are the enablers that we see in the ecosystem, how medtech is also growing with these technologies giving them a support pillar. Now, also important to understand when we say, okay, yeah, medtech is being developed, new digitalization is happening, this is happening, that is happening. There is a very important understanding to build when you talk about medtech is that there is risk classification in medical technologies. While a medical technology like a very small thermometer is no risk to an individual, but a CT or an MRI is a very high risk category where if that technology is not properly regulated, is not going through proper regulated studies, evaluations, then it becomes a challenge in the health system. We cannot bring them into deployment. Now again coming back to, we talked about medtech, new age medtech, how AI is enabling medtech. AI is now acting as a catalyst to these technologies that we've already been making. So I'm sure you all have somewhere or the other come across these terminologies where a complex neural network is being used or some deep learning is involved, how these models are being trained. So here is the concept that Himanshu was bringing in: Indian data sets, Indian models, information from within the ecosystem that is used by AI to become trained and support the clinical impact of that medtech, become more context relevant to that community or country where that technology is being deployed. So AI can help bring in actionable insights, maybe increase or improve the accuracy. It's definitely enabling the clinical decision support that we talk about, and on a lot of levels it's personalized care that AI is enabling. So in general, I'll just talk about the main areas where you would see medtech interventions now, even reaching down to the public health systems till the last mile. There are a lot of screening, early screening detection tools, point of care technologies that are being now integrated in the health systems. You would see a portable X-ray, you would see a portable spirometer, a stethoscope, a smartphone based retinopathy screening or a cervical cancer screening happening in the primary healthcare settings now, which is something that I would certainly call in the benefit of evolution that medtech is bringing in the health care system. A lot of cancer screening tools are also point of care now, and one does not need to be referred to the higher level of facility. Once the doctor suspects that the tools are point of care, they are available in the PHC or CHC, and that's a huge enabler. That AI layer is a huge enabler in that sense. We would also see diagnostics coming up. Now ECGs are becoming more easier to do at the lower facilities. You can do microscopy, you can do other digital pathology studies, because these medical technologies, point of care in-box tools are available even at the lowest lab care settings. You don't even need to have the hub and spoke model. These technologies are being right placed in those particular PSCs where they see the patient load for a particular disease type. You can see mobile vans fitted with these diagnostic tools and being taken from one facility to the other to have camp mode evaluations and in case of an outbreak and all. So this is how medtech has been enabling, leapfrogging the problem statements that we've all been talking about in the public health systems. I think we all know about continuous glucose monitoring systems, the remote wearables that we see. Smartwatches is something that we all are using. We now have cardiac monitor wearables, and these are really changing the face of healthcare, even for the lower facilities or the people who had never imagined health reaching to them. Also, you would say, talking about last mile, AI or medtech or technologies or health technologies are also evolving in the, I would say, the public health, not just the public health system, but the private health systems, or in bigger cities, larger urban settings as well. Now we have AI that does big data analysis. A lot of people now, whole genome sequencing has become that, if I would say, cost effective, that if you can afford a smartphone and you understand that you have a legacy of problems, health problems coming your way, you can get a whole genome sequencing done to identify your problem statements. This is how enabling AI is making access to modern healthcare or ultra advanced healthcare as well. You can do a biomarker study, you can do a drug development using this AI big data analysis, which I am sure you all have been reading in some news articles, some this happened, that happened. This is all real, this is happening in not just the rural or primary care settings, but now the urban and the more advanced communities as well. Another thing that we all have been talking about, hearing a lot, is software as a medical device. Which this is a very new understanding that people are having, but yes, softwares can also act as a medical technology, can completely help you screen or diagnose or understand the problem that you have, and it's just at the hand of your smartphone. So you can do a cough sound assessment to see if you are having TB or you are asthmatic. You can monitor yourself or a patient at home very easily. You could do an X-ray evaluation even for your own health records. There are so many newer technologies. Early screening for cancers is something that is picking up now. Blood biomarker-based screening is something that is coming up very frequently nowadays. And plus, yes, AI, when we talk about, most of us do understand advanced robotics, minimally invasive procedures, and 3D implants, prosthetics is something, yes, that there's also a part of MedTech. Now, why I've been talking about this, I mean, AI, MedTech, connecting the dots, as the session talks about. AI is not just, okay, artificial intelligence, definitely we all understand, but it is that intelligent layer that is enhancing the efficiency, speed, precision of whatever diagnostics, screening, or whatever investigations that we are trying to come along with. So some very, very, I think a few of the examples I've already talked about, but these are examples that you've been seeing deployed in the ecosystem, very, very frequently talked about names, where you can do a medical radiology with a software. You have molecular diagnostics reaching the benchtop of almost all facilities when we had COVID. Then point of care stethoscopes, cough sound assessment apps. You are also doing early warning signals. I don't know how many of you know, but there's a software or a platform called Blue Dot that has predicted COVID even before COVID came in the world, even before China reported COVID. So there are a lot of predictive modeling, integration of data that is happening in the universe or in the world in that general sense. And yes, that's acting as an enabler. Then definitely we are talking about all this to enable the health systems, the healthcare outcomes that we are talking about. So all healthcare operations are being enabled, right from ICU, bed occupancy understanding, to ventilator demands, to vaccine logistics. A lot of things you see now, AI is slowly, gradually picking up in the ecosystem and making, the two problem statements bridge, and that leapfrog is happening with AI. And then a lot of people, as I mentioned, are doing now genomic analysis. Wearable data is getting integrated with your day-to-day lifestyle. So personalized and precision healthcare is being enabled by MedTech. Yes, I mean, very, very broadly, there are 9 stages in which any innovator falls through a journey of when they start from an idea to when they finally commercialize. So this is the journey of an innovation or a health tech or med tech that happens. Just wanted to snapshot it for you with it. This journey is not easy, but India is being really a market where these health technologies are being developed at a very, very fast scale, and we see these innovations coming up. How, after the stages of this technology development, when a product is ready to commercialize, what does health system provide, or what does that medtech do? What is its fate is what I would want your attention to come here. Once your technology is ready, maybe one of you have friends who are developers of some software or some technology, and you fail to understand what happens once that technology is made. So I just want to give you a snapshot on, once that technology is ready, you need to go from your product readiness to your deployment readiness. It's not just you being made in the lab setting to say, oh, this is working fine. It has to go into the real health scenario in the health system on the PHC with the integration on the app of the Asha, and she should become comfortable to use that technology. She should feel that this is an enabler for me. This is giving me the kind of data that I would be happy to use this technology. It is integrated with the ABDM, and all these features then come in. So how we do that? We do a health workforce assessment for that technology, that they operate that technology. We do their, this is hand-holding for the literacy levels. I think this has been previously discussed as well. When we need to give them some literacy for how they can use these digital interventions, how we can do trainings for these health workforce. We understand the flow of the consumables and reagents that would flow. Then we also map, once a technology is developed, is the end user convenient, happy, being taking an X-ray that they took, and then the radiologist looking at that X-ray versus a patient screening in their own app or in the ASHA workers app to say, okay, that X-ray says that you don't have a fracture, or you don't have a particular case of TB or any other problem. So this end user experience, patient experience also matters when we talk about deployment readiness of any health technology. Then we have software licensing, costs, other very technical parameters I would not really go into, then app updates and biosafety, bio-waste. These are things, programmatic fitment, these are things that we always consider before we say that this technology is ready for the last mile. This is something that we want to deploy. We consider data storage, sharing, data privacy. We all talk about DPDP now. How service network is going to be there, what are the risks of using this technology, how do we replace or keep that technology working in that health system. Once all these aspects are integrated is when you see a technology seeing the face of, after this rigorous life cycle, you see a technology seeing the face of the public health system where an ASHA worker is using. I mean, just giving you this depth to say that what medtech is, what we usually talk is, it's a very rigorous process that it goes through. It's a very long and a difficult, a tedious journey that any medtech goes through to see the light of that health system where, this kind of leapfrogging that it can do, the enabling for the health workforce that we talk about it can do. So PATH, as you know, just a very, very one-liner that we have been deploying a lot of medtechs. We have been supporting a lot of medtech ecosystem when the technology is ready and at its final stages. We take these technologies to the last mile. We have test beds. We have PHCs that we saturate with these AI-enabled medtech. One such example is Satara in Maharashtra, where a few of the very, very common technologies which I feel most of us would either come across in some day or the other, these are being deployed. We see their on-field effect, how they are joining the dots in the real sense of they are ABHA, integrated, they are ABDM compliant, how ASHA or the health workforce is feeling the benefits of using these technologies, how we see the uptake of health in general picking up because such technologies are, coming up. And this is just a very small snapshot. I believe more and more as we are progressing, not just digital, not just medtech, digital medtech, AI integration, connecting all these dots is really enabling the health systems and bridging the gaps. Thank you so much.
Thank you, Divya, for this insightful reflection on medtech ecosystem and the transformating role technologies can play in healthcare. To bring these ideas closer to implementational realities, our next session will focus on practical medtech use currently being deployed in Andhra Pradesh. I'd like to now invite Sudhir Nadipalli from PATH to share on-ground experiences, implementational learnings and examples of how digital health and medtech solutions are being operationalized at the state level.
Thank you, Mania. And thank you, PATH, and as well as Government of Andhra Pradesh on behalf of whom I am presenting it for this opportunity. And thanks Himanshu and Divya for setting the context. So while you mentioned about policy and Divya mentioned about the dynamic ecosystem in medtech, so my presentation sits exactly at the intersection of policy and then as well as innovative ecosystem in India, especially from lens of Andhra Pradesh. Yes. Yeah, so apart from what you see here, actually at NHA, I sit in the Commissioner of Health and Family Welfare in Andhra Pradesh, and so I'm on behalf of PATH. We support Government of Andhra Pradesh in adoption of ABDM and digital health initiatives. So every week we see tens of startup owners or founders or somebody related to the ecosystem knocking the door of Commissioner office saying that we would like to test this technology in your state and we need your support, and we are already actually a commercialization stage. We want to get procured by the government through the official mechanism. So several purposes, and they come from different backgrounds and then different references, like somebody from academic, somebody from politician, or somebody from other secretaries. So seeing this, I think Government of Andhra Pradesh rightly thought about that what is that we can do to actually help them provided a landscaper kind of opportunity to test their technologies in the state, or in other words, like digital sandbox, that they can actually deploy those solutions and test it in the field, as rightly pointed out by Divya again, that the rubber meets kind of road situation for them. So yeah, so that is the genesis of it. So, and as also talked about, the procurement of AI or any digital health technologies in Indian, especially states, is still evolving. Some states could do it, and I remember an example from Madhya Pradesh where this particular tender to procure an AI solution got cancelled thrice for the reason that the regulatory frameworks are not very clearly laid out, whether it should be CDSCO or it is HTA should be done, or ICMR should do a clinical validation for this, or commercial validation is done, or it is like is a screening test, or it is a diagnostic test, or it is like helps only assist in some other mechanism. So these are the different challenges that are there. So basis that they have come up with this concept called MedTech Challenge. So they invited all the applications or like solution startups that are there in India to take this opportunity to deploy their solutions in Andhra Pradesh. And it is completely aligned with, it's not just like an open call, it's completely aligned with state requirement. And what state really facing are the challenges that they are facing in day in, day out in making healthcare accessible, available, and as well as improving the diagnosis of, say, several diseases. So that's the background to it. So then there is a RTAH, like how do they want to do it? They have a mechanism, created a mechanism called RTAH. RTAH stands for Ratan Tata Innovation Hub, which is a partnership with the government of Andhra Pradesh, partnership with Tata Trust. So they have actually created this platform where startups can actually apply this on their website. So this entire process, just to give a disclaimer, the entire process is done very systematically. Nobody knows who is reviewing their applications, and on a meticulous way. There's no bias, there is no favoritism to any technology, all that is taken care. Yeah, next, I can do that. So this is the platform that I've been talking about, so you can also test it, taking that. So it's open call. So, and these are the solutions that, like, once you hit it, then you will be able to see dashboard of, so they have been categorized into different varieties, whether it is like remote care, or whether it is like testing startups, different platforms have been categorized in, the startups have been categorized into different mechanisms. So this is the panel are kind of eminent individuals who have come together to form as a CAT, Committee for Applied Technology in Health, who have reviewed the applications that have been submitted to the RTH, and most of them are like, all of them are come from different backgrounds like industry, academicians, research, and government, and including some investors and funding organizations. So sorry for this slide, I mean it's busy, so but I thought this gives you an opportunity to see what has happened. So 300, close to 300 applications have been received, and 18 finalists have been selected based on after the review by different things. And just to give you a context, and they are all, most of them are like, as Divya mentioned, these are TRL 5, 6 and above. Those who have completed are kind of market ready solutions. So that's the background of their organizations. So 18 finalists could actually made it to pass through that funnel, narrow funnel, and they have been deployed in 14 districts. And this is a direct access to the what we have been talking from morning onwards, like stress test in the real scenarios, government facilities, and real world scenario where actually the high footfall is there in those facilities for those services, and it gave this opportunity for all these startups to build a traction with the government, how it works, in real world scenario, from prototype to pilot to if I have to ground it in the government system, how it actually works, what are the mechanisms, like, I mean, the learning is so, I mean, how do we quantify those, so much of learning that has happened over a period of time. So the 14 districts, and I've been given opportunity to deploy it in more than for 3 to 5 months for these innovations. And so as we have been talking about, so 12,000 interactions, like it's not, we are not talking about international data, we are not talking about national data, we are talking about very localized data that is made accessible to these individuals at these facilities in different parts of the facility. As models has to be trained on different data sets, and this is gave them a good opportunity to train their models on the localized data. So they are different, like eye health, respiratory, tribal, anemia problem in tribal. So each one is actually trying to address a specific problem that state was facing. So yeah, these are the different 18 portfolio of companies that have, startups that have been selected for it. And as you can see is like this has been categorized into air-powered, point of care device, smart monitoring, and then remote care telemedicine devices. So you can see the patients that have been tested on those solutions, and then the key outcomes that have been emerged from it. So I mean, as we speak, last week there is a final demo day happened, and each one solution from each of these categories has been selected as winners and has been provided a winning reward also for them for their deployment in it. So all in all, this gave these solutions a very good opportunity to test their models, and also all the learning that I was mentioning about working with the government and stuff. So that's the these are the innovations that have been. This is a snapshot of what have happened. For example, if you take Swasa, 7,400 tests has been conducted in one facility that have been deployed, and Remedio is also similarly. See the turnaround time or kind of diagnosis that has improved over a period of time with these innovations. This is another Rizovin. This is a heart monitoring device that has been deployed in Kurnool, and then InnaCell Science is a CPAP mission that has been deployed in Government Hospital, Kakinada. Cleanali is EHR integrated doctor trusting AI, not fearing it. So this is basically a clinical detection support system that has been deployed in Parvatipuram. Periwinkle, we also talked about, this is a cervical cancer screening device that deployed in Guntur. So there are many, I mean, 18 applications that I have been talking about, and these are all tested and verified in Andhra Pradesh. So the other outcome of this entire exercise is that, as I was mentioning, there are so many nuances that needs to be fixed in procurement. Government actually is seeing this as an opportunity to directly procure them after this rigorous exercise. Whoever has emerged as a winner in this can be given a possibility of giving a contract from the government side, like 1 crore contract to expand in the state itself. So while there are different mechanisms that are emerging on the procurement, I think this could be one that other states could also take learning from and try it in their respective states. So finally, the entire process is nurtured in Andhra Pradesh, but available for India and others. So thank you. Thanks for this opportunity.